大家好，我是梅孝维牙科院的林尚哲院长。Hello everyone, good to see you all again. I'm Sang-Chul Lim, periodontist. I welcome everyone to the Dentium Live Surgery show today. Also, I congratulate to Dentium Suncheon Symposium. I'm great honor to join this big symposium's live surgery as a moderator. On behalf of the Dentium company, I would like to appreciate everyone. Today, Dr. Chung was invited for this live surgery. He is showing to us socket management and implantation on anterior aesthetic area. This procedure will be introduced with the socket shield technique. I hope this live surgery helps you in developing your treatment skills and concepts on upper anterior aesthetic area. Thank you. Let's take a look at today's case. Today's case, socket shield or socket preservation in upper anterior. As you can see, upper 6 anterior teeth of patient failed already and is bad situation. So patient need to replace with implant-supported prosthesis. Today's patient, 84 years old male patient. So this one is CBCT view. Number 11, number 12, number 13 are shown to as follow. As you can see, especially number 13 area have apical lesion. It is not big, the small size apical lesion. It is accomplished with immediate implantation also. So today, Dr. Chung have 2 implantation on upper right area, anterior area, and 1 socket preservation. Okay, this one is number 21, 22, 23 area. This one is better than before one. So I think these areas all can be candidate for implantation, immediate implantation after extraction. This one is intraoral view of patient. As you can see, longer clinical crown due to reduced periodontium, periodontal and soft tissue recession. Number 12 and number 13 teeth already fractured and the remnant of the root. And we can see gingival swelling, swollen the gingiva and have some inflammation around this root remnant. And around tooth, number 22, 23 areas also not good situation. And this one is lateral view of intraoral view of our patient. This one is intraoral scanning. This scannings means a little bit more precise treatment planning. It is essential part for in future maybe the digital guided surgery or the virtual setup and also the final processes. So today's surgery plan as follows. First, actually number 11 and number 21 areas installed with a bright implant system. This one is, as you know, a Dentium brand new system. So maybe bone level implant systems will be installed, number 11 and number 21 immediate implantation socket area. And number 12 and number 22 will be preserved with socket preservation technique. At this time, Dr. Chung will be shown to us socket shield technique. So about the socket shield technique, as you know, remnant of the intact tooth fragment, remnant of this tooth fragment should be remained labial bone plate area. And then remaining the space can be replaced with the implant or just bone grafting for the socket preservation. About number 13 and 23 area, the canine area, will be installed with bright tissue-level implant. This time, the Dr. Chung planned for a tissue-level implant. So, very interesting situation. Bone level and tissue level of the same system, the bright brand new system. We can see all of these procedures, tissue level and bone level procedure. So, the diameter maybe 3.5, 9 or 10, 9 or 11 millimeter, and another part will be 4.0, 11 millimeter implant fixture will be installed. About the root shield technique, as you know, the mobility of the tooth is a contraindication. Cause of these mobilities prohibit osseointegration and bone healing and soft tissue healing. So, no mobilities of remnant of the tooth is essential part for root shield technique. And no apical lesion is necessary part for a safer and a comfortable procedure for socket shield technique. Generally speaking, about the treatment extraction site, especially with apical lesion, we can see we will proceed as follows. First, pre-medication, and second, curatives with hand instrument thoroughly. And number 3, grind out with carbide bar, small diamond bar will be used. And finally, we can use laser or HCL. This one is a similar case. Actually, already the fractured and failed number upper 6 anterior area. And as you can see, remove the remnant of the tooth and just only small fragment, shield part is remnant on the labial part, and then put the implant fixtures on the socket area. Immediate implantation with the socket shield technique. Final approach looks like here. A very nice final prosthesis comes out after this special technique, as you can see. So we can focus on labial contours, very stable and healthy labial bone plate and the soft tissues. It is a great advantages about socket shield technique. Another similar case looks like here, the single implantation. This one is very difficult situation, as you know, cause of it is not a symmetry part. So one implant, one natural tooth, it is very difficult to get the better aesthetic part. So in this case also try to, with the socket shield technique, remove of tooth fragment, and then just a small part of fragment should be maintained on the labial part, looks like here. And all of another procedures are similar to immediate implantation. The direction and the depth, all of this one is similar to ordinary immediate implantation procedure. And the implant fixture installed with the graft materials, filled with graft materials, and the soft tissues applied with the healing abutment. And after healing, we can see use this scan abutment for the digitalized final restorations comes out. So final processes looks like here. As you can see, just only one single implantation neighbor tooth is a natural tooth. Even though this situation, very difficult situation, as you know, when we have implantation aesthetic area, we can see very nice, well-organized, stable labial portion of soft tissues and bone level. And the final process is very natural. Okay, let's move to surgery room. Actually, Dr. Chung already prepared for the surgery today. Okay, please, Dr. Chung.
Very
Thank you.
welcome to today's live surgeries. Today I will place the 4 implant after extraction of 2 central incisor, and also lateral 2 incisors, and I will try to remain the remnant of the root tips, especially on the labial side, to preserve the extraction site, and also in the canine areas, and also root shield technique together with the 2 implantation and the bone graft together. At first, I will try the 2 extraction of the 2 anteriors for the easy manipulation of the surgical bars during the cutting of the root remnant. Before the surgery, I will cut down for the extraction of the 2 anterior tooths, extraction without any trauma. So usually for the extraction for the anteriors, we try to periotome like this, and try to complete cut. Also, when you do bone sounding,
of a traumatic extraction procedure, Dr. Chung explained all procedures sequence with a traumatic extraction. First, periotome and
rotational movement.
Yes, rotational movement using extraction forceps, very gentle and gentle. Already these tools the fractured. So this kind of situations can be happen frequently. And number 11, tools extracted.
Try again.
Yeah.
The root tips.
Yeah, try again, holding the remnant of the root and similar
gently.
action. Yeah. The focusing on the rotation movement, the forceps, holding the forceps and rotational movement with a gentle motion. And try again.
A little bit difficult too. So elevating with a little bit sharp elevator for root tip elevators.
Changing the instrument. He is using the root tip elevators. Yeah. The instrument insert the parallel and proximal portion, and feel and the axial motion, the luxation of tooth after luxation, and remove all the remnant of the tooth last.
Okay, and a little bit more elevating. 다 잘 보이죠?
All the elevating instrument should be located proximal or parallel area. Cause of this proximal and parallel socket is thicker than labial, so we can preserve the labial thin labial bone.
Also, this root is also very firmly enclosed, so also very good indication for the root shield technique of this central incisor. So I will, but there is 약간 움직임이 벌써 있죠.
So sometimes partial ankylosis has frequently happened in elder patient. This patient is 84 years old male patient, so the partial ankylosis between root and the socket is frequently happen. So during the extraction, some part is easily luxated, but another part of root is difficult to have luxation. But anyway, Dr. Chung already achieved luxation, so almost extracted of remnant of tooth root. This procedure is very important, as you know. Better the best outcomes starting with a traumatic extraction. Immediate implantation, especially on upper aesthetic area. Okay, so almost done. Actually, these extraction procedures are time-consuming. As you know, drill and implantation is very faster, can be achieved after this procedure. So, time-consuming and step by step, the procedure is a necessary part for better outcomes when you have immediate implantation on upper anterior aesthetic area zone. So, okay, so root forceps here. The fractured fragment is very difficult to get extract, as you know, the particulated and the easy to brittle, easy to brittle, the remnant of the tooth. So try again. So elevating again. The tip of elevate located on the proximal area between the root tip and the proximal site is the best location for the tip of elevator.
So, for reduce the trauma, and so after the initial drilling, I will try the two extraction. Well, sometimes for the easy extraction, I can cut out.
Okay. Dr. Chung is one or two go throughout. So use high-speed bar, Fisher bar, to remove the remnant of the tooth. Okay. When we use this high-speed Fisher bar, always this Fisher bar make a channel from the medial to distal. The medial distal channel is important part to separate the remnant of the tooth. Okay, so after that, try again.
흔들려도 잘 안 되네. 도와주려고 감사했지.
Actually, another remnant of the small fragment removed, and the small pieces, the part of root remnant still remain the labial bone plate area, but Dr. Chung decided to remove all the remnant of the root. So number 11 and number 21, the central incisor, both of the central incisor area, the tooth removed, and the use is curette. Hold the socket curetted thoroughly. And at this time, we can check labial bone situation. Maybe intact or not, or some penetration or some dehiscence. we can have a tactile sense using this instrumentation. Can you see tip of this small curette checking the labia side of the extraction socket? So Dr. Chung can recognize
very intact labial bone.
okay, intact labial bone here. Yeah.
And so, however, there is no apical region on the X-ray. For the confirmation of the detoxification, I will try to use the lasers in the apical area.
Yeah. So this
completely burn
detoxification
out.
procedure using a laser. This one is confirmation, the procedure. So we can use hand instrument, socket curettes, and small round bar for removing the remnant of the lesion. And sometimes we can use this laser or tetracycline HCl for the detoxification. So there are many methods for socket detoxification, and okay. The next step, tetracycline application. Dr. Chung preferred to use this yellow colored powder. This one is tetracycline with the saline. The normal concentration is 5 milligram per milliliter of saline, and then apply the socket area for this detoxification. Actually, normally 4 minutes in journal. In article, the recommendation for us about this application time, 4 minutes. Okay, so.
But we already use the razors, so in this situation, maybe a little bit less than 4 millimeters.
Yeah. Yeah, already use laser for detoxification. So Dr. Chung removed all these tetracycline powders soaked with the saline with the remnant of granulation tissues, top portion of the socket. Okay, so yeah, removing the granulation tissues, the upper portion of socket. Now this granulation tissues, frequently inhibit the osseointegration or fully integration between implant fixture and socket, or implant fixture top portion, collar portion, and socket tissues. So these granulation tissues should be removed thoroughly before the implant installation. Okay, removing all the granulation tissues around this socket top portion.
After that, let's try to insert pilot drilling to central incisor areas.
Yeah.
With the drill extensions, we can see the direction.
Yeah, direction is important, as you know. So
also before that, I will try to check the position and of the incised canals.
yeah, he is checking the incisive canal here. Yeah. Before using guide drill.
아주 얇은.
He is checking incisive canal first. This step for preventing the violation of incisive canal during the drilling. Okay, so remove remnant of the granulation tissues on the parallel side. Okay, so okay. So finally, he
incisive canal.
found the incisive canal and put the parallel pin into the canal, and start with the Lindemann guided drill with 1000 RPM with Salam. The actually entry point is important when you have immediate implantation, especially upper anterior area. So where is insertion, the starting point? So how can we measure the entry point for the drill? There are many different kind of methods to measure the entry point. The normally actually intact socket area maybe 7 to 8 millimeter below the socket margin, right? The parallel wall, from the margin of the socket wall, below the 7 or 8 millimeter on the palatal socket, the wall will be entry point for the drill, right? It is the ordinary and general method when we have anterior socket drilling, right? So checking the pass. During the drill and implantation, the direction and the depth of implant fixtures is very important factor. Okay, so try another socket with the same method, 1000 RPM with irrigation, the Lindemann guided drill, and entry point 7 to 8 millimeter below the top portion of parallel socket, the wall. Top portion of parallel socket, below the 7 millimeter is an entry point for the drill.
Change it into the 3-point final drills.
So, and the final drill here, actually, 50 RPM, lower speed without irrigation. This drilling sequence is most preferable of Dr. Chung. Dr. Chung always use final drill with this sequence, 50 RPM without irrigation, right? So after the guided drill with the Lindemann drill, and after that, when we use final drill, looks like here, the always pushing to parallel actions is necessary part. To prevent slippery, right? So the parallel walls with the cortical plate, so it is easy to slip during the drill. So first, Lindemann drill, make the entry point first, and then change the final drill and pushing the parallel the side with the downward, right? Parallel downward, pushing the downward and then parallel side is a very important action during the final drilling, especially a lower RPM sequence. Because of a lower RPM, it is we can feel the resistance of the parallel cortical wall. So sometimes we can use the pushing the parallel and then the downward. Important, the final drill action. So finally, we can get, looks like here, good direction, right? So, and after that, he is moving to lateral incisor. this tooth with the post.
Simply extracted.
So yeah, this post. So already treat with endodontic treatment. I always mentioned about these endodontic treated tools. Actually, in future, these endodontic tools will be a good candidate for implantation.
On this side, but tooth is have a mobility, so it's better to extraction completely. This side.
So it is not indicated for socket shield technique. Because of, as I mentioned before, the socket shield technique indication, first the factors, considering factors, is immobility. No mobilities of remnant of the tooth is important, essential, the considering factor when you apply the socket shield technique. So number 22, to extract whole remnant of the tooth root. Now number 12 area, Dr. Chung using the high-speed Fisher bar, separate the tooth root, make a channel, the mesiodistally, right? As you can see, first make a channel, using the Fisher bar, mesiodistally. And using this the elevator, separate the parallel fragment and remove parallel fragment. Right? Okay. So, and the small the part of root remnant on the labial bone plate, we can see the remnant of the small part of the root, right? And checking the socket here.
Okay. A little bit more grinding out.
Yeah. Slightly grinding out. Remove all the remnant of the part. So the important factors of this socket shield technique, the key is the small, how can we preserve the small remnant of the labial bone, the remnant of the root, shears. It is very important and important key factor. So we need to do something to learn and scale. Okay, so intact labial part of the fragment of tooth still remain there, and using laser for socket detoxification. This one is K2 laser. After detoxification with laser, and I think he is going to have
이게 두꺼운 거군요. 됐습니다. And try the bone sounding.
a bone sounding here.
Around this, around the 3 millimeters each side. In this side, 2 millimeters.
3 millimeter.
So around 3 millimeters. So there is no way. 유성펜이 있을까?
Okay, so Dr. Chung checking the remnant of tooth. The 3 millimeter.
마킹이 안 되는구나.
So he want remove all the remnant of tooth root and just only remained 3 millimeter. He wanna remain 3 millimeter here. So he used undercutting bar. This one is a specialized design. Only remove the top portion of remnant of tooth root. Not damaged lateral portion, even though the soft tissues and the socket were. And cutting bar have a blade, the bottom portion of the bar, so all the remnant of the tooth root make a plane.
For the efficiency of the cuttings, I will be changed to round bar.
Change round bar.
And then after the retractions.
Okay, so using the round bar, slightly reflection the flap and removing the remnant of the root shears. Looks like here. This procedure is a key for the socket shield technique, right? The meaning of socket shield is maintaining the labial bone plate. After extraction, as you know, simultaneously labial bone plate starting to resolve. So especially bundle bone, upper anterior area is just so weak for the blood supply. So when you have a flap reflection or after extraction or some procedures for the surgery, this weak bundle bone is easily to break out, gone away, or resolve without blood supply. So all these procedures is one of the efforts maintain and preserving the labial bone plate, right? There are many different kinds of efforts and methods maintain and preserve the labial bone plate. The first one is very well known, the sandwich technique for the GBR procedure. And another one is ice cream cone technique, Dr. Tanao. Also the GBR categories. But this one, socket shield, is another category. It's no bone grafting the labial bone plate, just remain the remnant of the tooth sheath for the preserving and maintaining the labial bone plate. It is very economical and inexpensive method, actually, as you know. So about this socket shield technique, as you know, 2010, Dr. Filzler introduced about this socket shield. So almost 11 years ago, Dr. Filzler introduced to us about this socket shield technique, the preserved labial bone plate. The previous one, before them, actually all of our efforts concentrate on the GBR procedure. How can we conserve labial bone plate after extractions, or make a labial bone plate, labial bone area? So Dr. Tano's ice cream cone techniques or some other the clinicians and sandwich technique or GBR procedures and many different kinds of GBR procedures are already introduced and applied. Today, Dr. Chung shown to us the very interesting the socket shield technique, right? So he is going to have decided about socket shield about number 13 and 23 area or so, have decided to have a socket shield technique. This one is, another name is root membrane technique, the same as socket shield, root shield, or root membrane. The different naming, but the same techniques, categories.
Here there is a root.
the first, checking the intact or not of the root. So intact root can be candidate for socket shield, right? Number two, actually, when you have decided the socket shield technique, make a channel from the mesial to distal, horizontal, the channel, using the high-speed Fisher bar for separate the palatal and labial the fragment. So, and gentle elevating or some other the procedures for remove the palatal portion, and then grind out slowly and a little bit more and more, and finally we can get the labial root shield, looks like here. But actually there are different categories about this root shield. The category 1, actually the class 1 is a lutein type, like the lunar type, looks like semi-lunar type, looks like this shield is popular. But another category also introduced about C-shape. C-shape shield is more bigger, covered the socket area. Okay, so another type is half C, the proximal and both of proximal, the mesial and distal, like this one. The two parts of the shield is a modified root shield technique. And finally, the parallel root shield also applied. So there are many the different categories about this socket shield technique. The popular one is semilunar, small remnant of the labial bone plate around there. And type 2, the half C shape, half, bigger than the normal situation. And mesial and distal, and finally parallel. So the four are different categories for socket shield technique. But today, actually, the labial, the semilunar type or half C type is most popular.
Around the bone sounding, around 3 to 4 millimeters.
3 to 4 millimeter. After bone sounding. Bone sounding means the located, dictated, the bone location. The marginal socket bone was dictating. And then we can proceed removing the remnant of root shears using taper bar. This one is very the higher skillful technique actually. So we need more practice for the performing this socket shield technique, right? So need more higher. But this technique is inexpensive compared to conventional GBL procedure. Faster healing and less cost for graft materials or some other biomaterials, and simple insertion, easy to maintain the labial bone. All of these are advantages about the socket shield technique. So this one is undercutting high-speed bar, like a flattening the top portion of the remnant of tooth. All of these procedures are performed after bone sounding. Bone sounding means checking the bone location, the top portion. Where is the top portion of the bone socket area? It means bone sounding. These procedures are a prerequisite factor Okay. Slowly ground out, slow. So finally, we have to maintain or remain the very thin layer. How can we decide how many portions, how much thicker portion of the tool's root laminate should be remained? How can we decide it? Actually, first socket size, and then the estimated the implant fixture size, and then because of this the technique, the first one, another considering factors, it is the prohibit actually contact implant surface to root sheath directly. Okay, so always prohibit, forbidden contact implant surface to laminate of the tool's sheath directly. So we need the gap between implant surface and root sheath. So this gap may be a minimum 1 millimeter. So estimated implant diameter plus 1 millimeter is the final, the room for the proper, the socket shield technique. So until there, we grind out all the laminate of the labial bone, labial root.
canine 루트가 굉장히 길어서.
Okay, so finally he got the 5 socket area here.
이제 드릴링하고 이리게이션 해주셔요. 1번으로. 미안해, 내가 드릴링합니다. Root tip still remained, so after drilling, we will completely remove all of them. At first, before that, I will try to drilling. 이게 턱을 약간만 들어보시겠어요? 네, 감사합니다. 라이트가 안 보여서
Very cautious procedures. Due to we have to remain and preserve the periodontal attachment apparatus on the labial side. So undamaged, no damage, undamaged.
Moved together, so I will instruction.
All
of them.
Yeah. He can feel
Maybe
the mobilities, remnant of the root sheath.
So completely removal of them.
He have
With
to
the root
decide
together.
complete remove. Okay.
So it was very difficult for me to do. 네, 됐습니다. Check the bone conditions. There is too much thin bone and no bone, so you must little bit membrane coverage on this side.
He can feel some penetrate situation on the labial bone plate area. So he have decided the GBR procedure after implant insertion. Okay, so the entry point is same as I mentioned before.
I finished the drilling to the 4.0 millimeters, and the cannon is very long. 레이저 떴을까요? 네. 멤브레인도 제일 얇은 거 하나만 준비해놓을까요?
He is using the laser also. Okay. Yeah, tetracycline HCl
detoxification.
applied for detoxification. Actually, the socket apex area.
이제 오른쪽으로. I tried to. Canal is very long, so
So he used Fisher bar, make a channel. But this Fisher bar moved only into the tooth area. Okay, so this Fisher bar they couldn't touch the socket wall or any more other areas cause of minimize the damages. So only move into the tooth root. Any other touch? Any other touch is not given when you're using the Fisher bar, right? So this high-speed Fisher bar is very cautious to damage the socket wall or some of others of the tissues area. So only constricted into remnant of the root area with Fisher bar and using the removing the remnant of the parallel portion of root. Yeah, so remove this part. Very gentle and gentle. Actually, canine is very difficult portion for sosial technique cause of curvature of root and a long root. So it is very technical, highly sensitive to technique of operator. So experienced operator doesn't matter, but beginner, actually, I recommend you strongly start with a central incisor or lateral incisor first. When you have a sosial technique. Okay, so separate.
So direction of the root is not ideal for the root shield techniques, but I will try to step by step finish.
Cause of curvature. So Dr. Chung mentioned about the tooth curvature. So, but he tried removing the remnant of the root. So finally, he wanna make very thin shield layer for the socket preservation.
이제 나우 프랙처는 됐는데 레디얼은 어떤 거 동요가 약간 동요도가 있긴 하네요. 예. 이쪽은 좀 약간 절개해서 하는 건 어떨까요?
Yeah.
앞에.
He have decided the flap reflection after incision.
Yes, in the apical.
Cause of he want to see the apical portion.
여기도 통이에요.
Yeah, this the flattening procedure is very important sequence cause of the frequent complication of this social technique. Sometimes we can see the internal exposure. Internal exposure means the after final lastration. We can see sometimes that this remnant of tooth fragment exposed during soft tissues around this marginal portion. It is the complication of social technique. So sometimes we have to remove all the top portion of root.
Only the lateral incisor can be a root shield. Besides that, only socket preservations. I'm sorry, due to mobility of them.
During the tooth separation, he can feel the mobility of remnant of root of the tooth. So he have decided to remove whole portion of the root, and whole portion of root will be removed.
Sorry, not to showing well about the root shield technique. Only to lateral incisors. Number 12 is available for them.
Yeah, remove the root.
There is a perforation to the labial side, so
Yeah, perforations.
there
Yeah,
is
perforation checked.
not so much intact bones on the apical areas.
Apical and labial have perforation of bony wall, so it is not indicated as occasional technique. So treatment apical portion, he make incision around the root apex area with a semilunar incision here.
왼쪽으로 이쪽으로 이거 미안해요. 고개 왼쪽으로 힘주고 계세요.
Yeah, we can see clear the apical portion, the penetration bony wall side. We can see the clear side of apical, the perforation socket area. So using the round bar, removing the remnant of contaminated area. A very big defect, as you know. These areas, as I already mentioned before, when we look at the CBCT before starting the surgery, previous PPT, I explained about apical portion of the lesion of apex of canine area with CBCT. When you see the CBCT, before starting the surgery, we are focusing on apex and labia bone plate area. Cause of especially this upper anterior labial bone plate is very thin, extremely thin. The ordinary thickness under 1 millimeter, as you know, under 1 millimeter. So, and also the bundle bone, top portion of socket. So it means after extraction, simultaneously starting to resolve process of labial socket wear. So we have to, we need to do something for preserve and maintaining the labial portion of tissues. Even though the soft tissues and hard tissues doesn't matter, the both of them should be kept. Some of another the efforts like GBR procedures or some bone graftings and socket shield. Anyway, it doesn't matter. The big defect around apex portion of 1/13 canine area.
이쪽은 드릴링 다 끝냈죠?
Okay, so he is considering about
이쪽은
the pass
11
and the insertion.
그냥 40111 골리식하고 해야죠. 그리고 센트럴 인사이즈하고 다 해서 끝냅시다.
Yeah, all of prerequisite the treatment was done. So now it is time to implantation. It is time to placement of implant picture. Today, Dr. Chung is using the guide kit and the bright implant system. This guide kit have a blue ring looks like here. 7 millimeters. Can you see the 7? It means diameter of blue ring. So the final, the crown, mesodistal diameter, we can measure the before final processes. So when we have an implantation with a drill with this blue ring, we can estimate and prospect the final lacerations diameter, so we can do the implantation, the ideal position. When we have a manual type, this guide kit is very useful.
캐나다 404 레벨은 어떤가요?
All of these manual type procedures are an essential part, even though you try to have a digital guide surgery. When you have a digital guide surgery,
센트럴 인사이저만 한 번 더 체크해 볼게요.
who designed for proper position of implant fixture? Your technician or some assistants? Anyway, it doesn't matter. However, final confirmation is belonging to you. So you need know about the three-dimensional positioning. Right? You need to know about three-dimensional positioning when you have even though the digital guide surgery, right? So anyway, this manual type freehand this surgery is very important and essential part. It is practicable for your future the ideal digital guide surgery. Either the manual type freehand surgery. Okay, so before implantation, he need more. Yeah, he used laser, removing the soft tissues. this K2 laser is versatile. Sometimes this laser is used to remove the soft tissues and detoxifications. And there are many different kind of modes available.
Two central incisor labial bone is very intact, so we place the two tissue level implant with the bone graft on the upper anteriors at first. 그리고 렌스를 한 번만 더 잡을까요? 뎁스 게이지 오케이. 조금 충분 11mm도 충분할 것 같고, 아니면 9mm로 3.5mm 두 개씩 립합시다. 본 그래프팅 first, the central incisor.
About the central incisor area, bone grafting first and implant insertion.
Yes. 고마워요.
Yeah, osteon graft material. This one is alloplastic, synthetic bone graft materials. This one is the slow resolving the potential, so it is very easy to keep the volume, especially this kind of socket area. So contour augmentation, socket preservation, GBL portion, it doesn't matter. Anytime you can use these collagen osteon 3 graft materials, synthetic bone, higher potential to preserving the volume maintenance and also the bone formation function. So, Dr. Chung, grafting first and then implant insertion. Some of other surgeons, implant insertion first and then grafting. It doesn't matter. It depends on surgeon style. When we have grafting first, actually a compact filling is easily to get. So this one is preferred method of Dr. Chung. So this one is brand new. The bright implant system, tissue level. Diameter 3.5 diameter. Length
9 millimeters.
Is 9.
Yes.
Easy to get the higher insertion torque. Simple insertion procedure and getting higher insertion torque. So like this kind of gap area, easily applied. So very simple. Just already do 2 implant insertion with a higher insertion torque. Tissue level here.
Is relatively lower. But due to polymer, so after changes in the metal, will be better.
Yeah, I think so, Dr. Chung. Remove the cap, the polymer cap.
중간 거 너무 짧지 않고.
And connect with healing cap.
괜찮을 것 같아요.
This one is healing cap, metal healing cap here. As I mentioned before, the direction and the implant insertion depth is very important part. Especially
이 정도면 스캐닝, 스티칭 괜찮을 것 같아요.
upper anterior area. Cause of this one is this area is aesthetic.
괜찮을까?
So aesthetic part is important, as you know. So
네, 좀 약해서.
scan comfort cap,
스테이블.
connect. This one is scan comfort cap. This cap versatile for using for intraoral scan, they're also using as a healing abutment.
Around 95. A little bit lower.
Yeah, this one is ISB, the mobility test devices. Actually, the stability checking devices. This one is very, the can be transformable, the ISQ value. So this number 13 area, they're covered by collagen membrane on the labial socket area.
까지로까지 다 끝냈죠? 네. 오케이. 본 그래프도 준비하고. 네.
And the bone grafting. Yeah. All the exposed labial bone plate area covered by collagen membrane, the big size collagen membrane. So Dentium collagen membrane is the preferred for me. For me, actually, I always use this Dentium collagen membrane because of this collagen membrane is long-lasting. So for big GBR site, it doesn't matter. This collagen membrane until over than 6 months can be survived and maintain all this GBR area. So long-lasting collagen membrane should be chosen when you have a big defect for the GBL situation, right? So I always choose Dentium collagen membrane. This one is reliable for me, GBL procedure, and then also easy to handle and stiff enough. So when you have a L technique, like Dr. Donald Chung suggested about L technique, so combined with this kind of long-lasting membrane, you're getting better result, right? So for me, actually, when I have a L technique for using the collagen, the graft materials, actually, I always use this collagen membrane for the guaranteed result. So bone grafting was done.
4.0, 11 millimeters.
Yeah, 4.0, 11 millimeter. Yeah, this one is bone level, right? So previous one tissue level, this one is bone level. This price system is very interesting. It's just the same drill condition. We can choose bone level or tissue level, doesn't matter, right? So ordinary system, at the first time, we have to decide bone level or tissue level. Depending on your decision, all the drill sequence or some procedures are different, right? So a different way at the starting time point, starting line. But this price system is the same. Starting line is same, and finishing line is different. During the drill sequence, the same between tissue levels and bone levels. And finally, you can choose either one. Tissue level is better condition at this time. Okay, tissue levels, I will insert tissue level on this side. But another side, bone level is better for tissue level. Okay, doesn't matter. Yeah, just to put the tissue level pictures can be accepted. So this price system is very versatile and interesting system. So all the drill sequence are very simple and minimized and the same, even though the tissue level or bone level. Either tissue level and bone level doesn't matter, the same drill sequence. And then finally you can choose the either tissue level or bone level, doesn't matter. So Dr. Chung today tissue level implant inserted both of central incisor areas, both of canine areas, he used ready bone level 1, and actually this 23 areas also, I guess, Dr. Chung insert bone level implant. This right level is very simple drill and easy to install. Actually, this brand new system doesn't need countersink, right? Can you remember during the drill sequence? No countersink drill, right? So just final and insertion. So like this socket, the extraction, the immediate area, it is one of the advantages. Yeah, so faster insertions are doing well. Yeah. In 5 minutes, just 5 minutes, 3 implants already done, right? Yeah, it's amazing. Yeah, so 4.0 diameter, 11 millimeter, 11, right? So yeah, direction and depths. Yeah, good. Yeah, very nice. Well done. So, what do you think about this? The direction and the depths. Yeah, very nice, perfect. Yeah. Yeah, once again, function and shundu is可以. function 可以, shundu 可以. Yeah. Okay, so now the remnant of graft materials removed. So excess of graft materials sometimes prevent soft tissue healings or cell integration. So remnant of excess part of graft materials should be removed for better soft tissue healing, right? So, yeah. Number 12 and number 22, lateral incisor areas, socket preservation. Number 11, 13, and 21, 23, implant fixture installed actually. So the both of canine areas applied by collagen membrane covered labial bone plate cause of due to some small perforations. Number 23, actually number 13, as you know, as you can see, big apical lesion and defect. So big GBR procedures combined with implant insertion. Yeah, finally, he is doing the suture, the modified horizontal suture technique. This suture is 5-0 ethylene. Anyway, monofilament sutures are used. Okay, so when you have implant surgery, like the black silk, like this kind of sutures should be prohibited, right? So always use monofilament sutures for prevent infection, micro abscess after during the healing period. He is doing the horizontal mattress suture. Yeah, so far so good, very nice, excellent. Yeah, procedures are performed. Very skillful and faster. Minimize. Actually, this technique, the flap this, so minimize trauma. So it means faster healing and easy to preserve labial bone and marginal tissue area. It means finally we can better aesthetic outcome than the flap open situation. So even though number 13 area, for removing the apical lesion, Dr. Chung have decided to have a semilunar incision, protect labial bone, blood supply, and conserving the labial bone plate. Right? So full thickness flap reflections are avoided for minimize surgery concept. Right? Today, you can remember actually a flapless surgery. Flapless and just a small semilunar incision. This one is for removing the apical lesion of number 13. Okay. So, yeah. Yeah, Dr. Chung is going to finishing line today. Now, please stay your seat. Please stay there. Because after this surgery, we can see very impressive impression technique. Dr. Chung shown to us very interesting impression technique. So, yeah, you can expect. So, stay your seat. Stay tuned. The suture is not the end, not the ending of today's surgery. Part 2 is waiting for you today. So after surgery, we can see a very interesting method for impression.
조금만 담궈보세요. 네.
Okay, so yeah, today's surgery concept was minimize surgery. Today's concept nowadays actually minimize surgery concepts are popular, prevailed. So flapless or minimized flap and guide surgery, even though the freehand surgery, as you can see today.
여기에 봉합 하나 더 할까요?
Okay, so he want to do something more, just one stitch, okay? Yeah. So after suturing, after surgery, immediately we can get the impression with the scan abutment already connection with the implant fixture, and then this impression scanned by model scanner, and then we can make the temporary processes designed by the program, right? So, yeah. Okay, after surgery, we can take impression, the conventional technique, the bite tray with the rubber impression material. This one is PDRN, the reduce the swelling and the faster soft tissue healing. It is the hidden weapon of Dr. Chung. Yeah. Yeah, he always have a hidden weapon.
또 준비했어요? 그렇죠. 아니, 좋아요.
Yeah. This one is PDRN, like the growth factor. To stimulate the soft tissue healing and reduce swelling of the surgery site. So, yeah, very nice. Well done.
Yeah, very fortunately we have some flat surfaces on the labials, but still the stability is lower. So for the temporaries, maybe 3 to 4 weeks later, and the 60 number 53 still be little bit lower, 60 around, so still be lower for the temporaries. So
this device is checked.
Yeah, weight. Yeah. Usually in these situations, and we can use the temporary for the S6 retainer or fix the temporary 3 or 4 weeks later, because and 3 or 4 weeks later the mobility became to be stabilized a little bit more. For that, and there are 2 ways for them. One is the intraoral scanning or impressions, but at this time I show you how to impressions with the bite tray.
Yeah. So
한번 본 뜨겠습니다, 선생님. And intraoral scanning 다 보여주면 어떨까요? Yeah. We show you how to bite tray impression and also the intraoral scanning.
Okay. So we can go both way, intraoral scanner.
At first with the bite tray impression.
Yeah, bite tray impression. Okay.
꽉 물어보세요.
꽉 물어보세요.
옳지. 그 손으로 턱을 받치셔도 됩니다. 한 손은 이제 올리셨어요. 손으로 턱을 이렇게 구들등을.
This bite tray technique are very
꽉
useful.
물어보세요. 믹싱 할까? 파티 믹싱.
The bite tray, very useful. Actually, one shot, 3 kills. Actually, we can get.
다 잘 됐어요.
Yeah.
고생하셔서 힘드셨죠? 예, 이제 본을 금방 뜰게요.
크게 해보세요.
The opposite arch impression and the bite and the implant site impressions. All of 3 registrations index can be achieved by just only one shot.
크게.
This bite tray. So this one is very simple and useful method and technique. Even though,
그리고 혀로 젤을 살짝 밀어보세요.
okay,
살짝
very nice.
이제 밀지 않으셔도 돼요. 예, 됐어요. 가만히 이제 굳을 때까지 이렇게 물고 꽉 물으셨죠? 꽉 물으셔야 돼요. 물으셔야 돼요. 물으셔야 돼요. 꽉 물고 물으셨어요?
Bite firm. Patient should bite firm during 5 minutes for setting these lower impression material.
스캐닝도 보여드릴게 어떨까요? 됐을까요? 이걸로 그냥 끝내죠.
Okay, so this one is a new technique. The intraoral scanning is popular now, but this bite tray registration technique is very simple, even though the conventional type, right? During 5 minutes, bite firmly, and then we can get the bite registration and also 2 negative impression, the opposite dentition. And okay, so after that, we can see the scanning procedure in at the same time point of panoramic view post-op and CBCT. So let's move on to the prosthetic. Let's move to the after this procedure. Thank you for your patience. First of all, I got the 2 questions about today's surgery. Very excellent and good question. Number 1, there are still more cases where oral scanners are used to scan the oral cavity directly, and in most China areas, analog impressions are carried out. So, what do you think about the expected effect of performing the impression scan compared to scanning the oral cavities? Basically, impression scan doesn't need any device process. right? It's a conventional technique, inexpensive and effective technique. Basically, dental lab technicians want to have a model. They want to work on the model. So if you get the impression scan with a byte registration, you can get the model also and the same digital data from the impression scan, right? So compared to oral scanner, this one is simple and easy, but the device needed. You have to purchase the expensive devices. And the one big different thing is model free, no model. So the first of all, I suggest you impression scan with a model scanner is the best option for you at the first, and then co-work each other, your the laboratory technician, and then moving to intraoral scanner is a more acceptable option. And number two, what are the proper indications or long-term perspective of root shield technique? Basically, root shield technique is one of the efforts of conserving, maintaining the labial bone plate and labial apparatus. Actually, 2019, Dr. Zhou Yanmin in Jilin University published about this socket shield technique with PDF. So if you are interested in this article, you can find Nature, the article, the stores, Dr. Zhou Yanmin. So they also have published. So the proper indication is endodontic problem tools. Endodontic problem, it means no any other periodontal compromised case. And another one thing is tooth fracture case. The accidental or tooth fracture is a good indication for socket shield technique. So anyway, intact tooth fragment is an essential and necessary part to maintain and proceeding the socket shield technique, right? So it is inexpensive also, and good preserving and well maintaining the labial bone, even though the very thin layers, and good options for anterior aesthetic implantation, immediate implantation. Okay, so let's move to the post-op, the panoramic view, and the CT and scan. Prepared or wait a second, please. Yeah, we will show you. Okay, this one is panoramic view post-op. As you can see, very nice, well done implant installation. The canine area 4.0, 11 millimeter bone level implant installed, and central incisor. This one is tissue level, 3.5 diameter, 9 millimeter. A very nice, well done installation. The actually direction and the depth of implant fixtures are very nice, well. So the platform is good. Okay, next. Yeah, CT view. As you can see, number 13 area, big defect of apical portion. So this one is bone grafting on the labial part of implant fixture. Number 11, yeah, very nice tissue level implant. Number 21, also very nice. Number 23, ideal portion of implant fixture. So all of these are acceptable for the screw retained final processes because of very nice, well done the direction. Okay, okay, and the scanner, yeah. Okay, after bite registration, bite tray, so lower part, the opposite dentition, upper implant surgery site, and bite also automatically achieved. So one shot, 3 kills, very effective bite registration technique. So moving to a scanner of a model scanner, this model scanner is popular devices on your laboratory, the laboratory technician. So everybody have the devices, scan devices actually in your laboratory. So after take this impression, the moving to scan the model scanner, we can get the digital scanning files. Looks like 3D dimensional. So yeah, this one is the procedure, normal procedure. The take impression and trimming and into the model scanner, and then we can get the digital files like intraoral scanner. So what is big difference? Intraoral scanner directly scanning into the patient mouth. So sometimes this one is easier and faster, but sometimes, unfortunately, this one is make some noises or inaccurate part. So sometimes this one is the model free. Model free means no model system. So your laboratory technicians don't like model-less working, right? So they only they want to have a model, the stone model, at every time for their laboratory work. So if you take this kind of bite trail registration, you can give this digital impression information and also the stone model. It is very big benefits. So after that, after this scanning, we can see like very nice, well done digital files. This one is almost the same, I think better than intraoral scanner for more accurate information of digital. So the patient happy and your staff and we can also satisfied about this kind of method. Okay, thank you joining this live surgery show today. I especially big thanks to Professor Wu. 谢谢吴布林老师，谢谢大家，再见。